This is chapter 6, and we will be looking at the last portion of this chapter, which is actually the knee. If we look back at anatomy, we know that a portion of the knee, the distal portion of the knee, is made up of the tibia and fibula. And we can look at this anterior view and look at all the anatomy that is required for us to know. When we look at the anterior view of the fib, remember that it's important to understand all the anatomy of the anterior crest, the body or the shaft of the tibia, the medial and lateral malleolus. We have the distal and proximal tibiofibular joint. We have the articular facets at the top of the tibia that articulate with the distal portion of the femur. We have the medial and lateral condyle, and then we have the intercondyloid eminences at the top up here with the articular facets, these little points up here. Now, those articular facets, which are on top of the tibial plateau, that is what articulates with the femur. And when we look at this laterally, remember that those articular facets slope posteriorly from front to back 10 to 20 degrees in relation to the long axis of the tibia. Now, why this is important as far as the knee is concerned is because when we do an AP knee, the central ray has to be angled in order to be parallel to the tibial plateau. And that's how you would demonstrate an open joint space, is that your central ray needs to be parallel to this tibial plateau. Okay, so this top line right here, your central ray is going to have to come in that same exact way. Now, how we end up knowing that how much to angle for that, we angle between 0 and 5 degrees, and there's also something that matters as far as which direction do we angle. So when we do an AP knee, we actually measure the patient from their ASIS down to the tabletop. Remember, their ASIS is the anterior superior iliac spine, that kind of bump that juts out when a patient lies on their back. So we measure from there all the way down to the table. And if the patient measures less than 19 centimeters, we end up angling 3 to 5 degrees caudal, or towards their feet. If the patient measures between 19 and 24 centimeters, there's no angle on the tube. And if the patient measures more than 24 centimeters, we end up angling 3 to 5 degrees cephalic. Okay, so what that actually has to do with is, in reality, it's basically the size of their hips and their buttocks. If they're very small and tiny, then you end up angling 3 to 5 degrees caudal, because what's going to happen is the tibia is actually going to bow, the way it bows backwards. You don't need as much, the angulation goes the opposite way in order for you to be parallel to that tibial plateau. If they measure between 19 and 24, there's no central ray angle, because the way their body habitus is, it would come through and be parallel to, it would end up being parallel to the tibial plateau with no angle. And if they're a little bit thicker, or more than 24 centimeters, then you're going to have to angle 3 to 5 cephalic in order to be, again, parallel to that tibial plateau. So this is very important, and this information can be found on page 218, also when we look at the AP knee image. Now, going back, the knee is actually made up of the proximal portion of the tibia and fibula and the distal portion of the femur. So we have the distal portion of the femur and the proximal portion of the tibia and fibula. So when we look at the femur in the anterior view, and this can be found on page 219, it is actually the longest bone in the body and also the strongest bone in the body. And when we look at this, you can see that they show you this 5 to 15 degree angle right here. Basically, person is standing in erect anatomic position and the distal femoral condyles are parallel to the floor, the shaft of the femur is actually at an angle approximately 10 degrees from vertical for an average adult. Meaning, when these are parallel to the floor, okay, that line there represents, when it's parallel to the floor, this would be perpendicular to the floor, but the femur actually runs between 5 and 15 degrees from perpendicular. The angle's greater on a shorter person with a wider pelvis, and it's a less of an angle on a taller person with a narrow pelvis. So in general, the angle is greater on a woman than on a man. Okay? And that comes into play again with our knee positioning as well. So when we look at the anterior view, you can see up here you have the head of the femur sits in the acetabulum of the pelvis to form the hip joint. We've got the body or shaft of the femur. You have the patella, which is our largest sesamoid bone. You have the patellar surface. And then you have the distal portion of the femur that we'll look at a little bit more in depth on this next picture. All right, if we look at the femur from the posterior aspect, notice it says note the 5 to 7 degree angle as shown at the distal medial and lateral condyles. So you've got medial condyle right here, lateral condyle right here, and they're telling you that there's a 5 to 7 degree difference between the two. Now, the medial condyle ends up coming down a little lower or more distally than the lateral. You can see this one comes down further than the lateral condyle. And it says that that's why the central ray is actually angled 5 to 7 degrees cephalic for a lateral knee, because what you're trying to do is cause both condyles to be directly superimposed when the femur is parallel to the IR. Okay, so because of that initial angle we looked at with the femur, that 5 to 15 degrees, and because of the relation between the medial and lateral condyle, if we angle 5 to 7 degrees cephalic on a knee, we'll actually put both the lateral and medial condyle right on top of one another for the lateral knee, which is important. That's what you're attempting to do. So you've got the medial and lateral condyle. Then you have the medial and lateral epicondyle, and epi meaning they sit above. So epicondyle is above the condyle. You have the adductor tubercle, which is on the medial aspect of the femur, because this is a posterior view. You've got the popliteal surface, the intercondylar fossa or notch, and then the body or the shaft of the femur. Now, when we actually look at the distal femur and the patella, where it's actually showing you an inferior view and a lateral view of the knee, these can be found on page 220. They're referencing that this is the popliteal surface. You've got the patella sitting here, the surface, the patellar surface of the femur, and this is actually the fibula. And then if you're looking inferiorly, this would be looking up at the femur, like if you were sitting on top of the tibia and fibula. You've got the medial condyle and lateral condyle, medial and lateral epicondyle, and then you can see the patellar surface and the patellofemoral back here. Okay, and that's an inferior view. This is a lateral view of the distal femur and the patella. When we actually look at the patella, it's interesting because normally when we think apex, we think like in the lung where the apex is at the top, but actually the apex of the patella is the bottom portion of the patella, the pointed portion of the patella. And then the top portion is actually the base. So at the top, you've got the base, the superior border, and in the inferior surface, you've got the apex. And then if you look at it laterally, the posterior surface is very smooth. The anterior surface is very rough on the patella. If we look at the knee joint itself in an oblique, I only put this in there to show you because we tend to hear a lot about ACL, MCL, the cruciate ligaments. So looking at this, it just shows you that you have the patellar ligament here that anchors the patella. You've got the collateral ligament, the lateral collateral ligament. You can see the posterior cruciate ligament, the anterior cruciate ligament, or your ACL, which you're looking at. So not that we have to know a lot about the muscles and the tendons, but just interesting when we look at that anteriorly, you can see your ACL or your anterior cruciate ligament, your posterior cruciate ligament, the fibular collateral ligament right here, and then your medial collateral ligament or your MCL. So ACL, MCL, PCL, LCL. A lot of times you'll have patients that'll have injury, especially to the ACL and the MCL, usually sports injuries. So just to kind of put that in perspective of where they actually sit. And that can be found on page 221. All right, if we look radiographically at the anatomy and correlate that to the image itself, first we have an AP of the left knee, and you can see it's actually cut off a little bit over here, which is just the way the picture was. It wasn't anything that that I actually did when I put it up. It's just that's how the image was taken or cropped. But letter A right here, you have the medial and lateral intercondylar tubercles. Okay, that's letter A. B, which is kind of hard to see because it would be up here, is the lateral epicondyle of the femur. And then C is the lateral condyle of the femur. Now it's easier to look at H and I. H is the medial epicondyle. I'm sorry, G. And then G is the medial condyle. So you've got condyle, epicondyle. Same thing here. You would have condyle and epicondyle. E represents the tibial plateau or the articular facets of the tibia that articulate with the distal portion of the femur to form the knee joint. We said medial condyle of the tibia is actually down here. You've got the medial condyle of the femur and then the medial epicondyle of the femur. And then you can make out right here the patella, and you're actually visualizing that through the femur. So if we outline that, kind of hard to visualize it until you see it. Okay. And then the base would be up here, and the apex is down here. So once I erase it, you can kind of make out where the patella actually is. Right? And that's an AP left knee because the fibula sits lateral, the tibia sits medial. If we look at a lateral knee, you might remember that I said we have to superimpose the medial and lateral condyle. And this is actually perfect, really, really, really good knee. If I kind of outline, you can see one condyle is right here. Sorry. And then the other one is actually right here. So pretty near perfect superimposition of those. Really, really good lateral knee. Okay, so A is the base of the patella because we said that's at the top. B is the apex of the patella. C, you've got the tibial tuberosity. Now that comes into play. That tibial tuberosity comes into play because we said that sometimes what can happen is that actually gets pulled away from the tibia, and that is the condition of Osgood-Schlatters disease. And the tibial tuberosity is a rough prominence on the mid-anterior surface of the tibia, and it's the distal attachment of the patellar tendon, which connects the large muscle of the anterior thigh. And in younger people, that tibial tuberosity can actually separate from the body of the tibia, so that tuberosity actually comes off of that. The tuberosity is pulled away, and that condition or that pathology is called Osgood-Schlatter disease. All right, and we can, I don't know that I have a picture of it in here, but it is actually in your pathologies on page 226. It's most common in boys 10 to 15 years old, and it's usually the result of an injury when the patellar tendon detaches part of that tuberosity that gets attached. And if it's severe enough, they can actually put the patient in a cast. Okay, so tibial tuberosity is C. You've got the neck of the fibula, which is D, the fibular head, the apex of the fibula, the superimposed condyles of the femur, and then this is the patellar surface of the femur. In this picture, now remember I said that this one is really good because they are pretty much perfectly superimposed. When we look at this next lateral, okay, this next lateral knee, right lateral knee, you can see the adductor tubercle, which is right here by letter I. Okay, they're kind of pointing out, comes out just like this. Okay, adductor tubercle comes, adductor tubercle comes down and then up like that, little bump on there. All right, that's important. That adductor tubercle is actually on the medial condyle. And then J, you've got the lateral condyle. K is the medial condyle. So let me try to show you this. Okay, so lateral condyle is J. So you've got lateral condyle coming down like this. That's lateral. And then we'll do medial. Comes down. You've got the adductor tubercle. Okay, so J is the red is the lateral condyle. The green is the medial condyle, and that actually has the adductor tubercle on it. And these are not superimposed. And the medial condyle is sitting more posterior, right? And in order for the medial condyle to sit more posterior, think about that the medial condyle is medial, so it's a right knee. So when you put your knee in a lateral position, for the adductor tubercle to be posterior, it means the knee is under rotated. It's not, the patient is not rolled up on their side enough because that medial condyle is sitting back. So if you had your knee lateral and the medial condyle is on the medial aspect, the only way for that to be behind the lateral condyle or the adductor tubercle to show behind this is if your knee is under rotated. So if you rolled forward more, those two would actually come on top of each other. Okay, that's probably one of the most difficult things for new techs and student techs to figure out is which way, when you have to go repeat that knee, which way do you have to do it, because you have to know which condyle you're looking at. So we try to look for the adductor tubercle. We can also look at the head of the fibula in relation to the tibia, because what happens with this, again, if you put your knee lateral, the head of the fibula is too much under the tibia. And typically when it's properly positioned for the lateral, if you kept rotating, then this fibular head would come back more and there would only be partial superimposition, not near as much superimposition of the tibia over the fibular head. All right, now we'll look at the patella and the actual knee joint and the space in between there. So letter A, this represents the patella. B is the patellofemoral joint, which that is a really good, this is called a sunrise view, where we actually image the patella and we image the joint off of the femur. All right, so patellofemoral joint. C is the lateral condyle. D P is the patellar surface of the femur, and then E is the medial condyle. So again, really good sunrise view that we have going on right there. So it's just kind of an overview of our anatomy. So we have the AP knee, a really good lateral knee, a not so good under-rotated right lateral knee, and then we have our sunrise view. All right, now, as far as a knee, when we look at a routine knee, and if you look at your cheat sheet, a routine knee actually has 5 views. There is an AP, 2 obliques, a 45-degree medial oblique, and a 45-degree lateral oblique, a lateral, and a sunrise view of the patella. Okay. If we look at the AP knee, this is on page 246. We're at a 40-inch SID. You're likely on a 14x17 or 16x16 IR. And typically, most adult knees are greater than 10 centimeters. You could always measure their knee. But if it does measure greater than 10 centimeters, then we do need to be in the bucky so that we can utilize the group to help clean up the scatter from our image and improve our contrast. The technique on this is 80 kVp at 4 mass. The patient pretty much lies on the table. You want to make sure there's no rotation. What you need to do is internally rotate their leg 3 to 5 degrees in order for the knee to be in a true AP. What you're basically trying to do is get the interepicondylar line parallel to the IR. So you slightly internally rotate the affected leg. Now, for an AP knee, the central ray has to be parallel to the articular facets. And in order for it to be parallel to the articular facets or the tibial plateau, this is where we actually measure the patient from ACES to tabletop. And if they measure less than 19 centimeters, we angle 3 to 5 degrees caudal. Typically, according to the book, it says the patient has thin thighs and a thin buttocks. So 3 to 5 caudal. If they measure between 19 and 24 centimeters, that's an average size person with average thighs, average buttocks. There's no angle on the tube. And if they have really thick thighs or a bigger backside, then you're going to angle 3 to 5 degrees cephalic. And the angulation, the either zero angulation or degree of angulation, is to end up making the central ray parallel to the tibial plateau. All right, so that takes care of your angulation in order for it to be parallel. And then your central ray is actually placed 1/2 inch distal or 1/2 inch below the apex of the patella. So you would find the apex of the patella, you palpate the patient's patella, and then you go 1/2 inch below to give you your central ray. And it looks like on this particular patient, they must measure between 19 and 24 because there's no angulation on that central ray. So in theory, what will happen is that central ray will come right down and be parallel with that tibial plateau, which will give you a nice open joint space. Okay, so you measure ACES to tabletop to determine amount of angulation. You can also palpate ACES to tabletop. We'll talk about this when we look at pelvis, but that's how you can make sure that your patient is not rotated. If you put your hands, your bilateral hands on their ACES, your hands should be parallel to each other as well as parallel to the table, and then you know your patient is not rotated. Right? And again, that's on page 246. Then we have 2 obliques. Oh, I'm going to look at the image. So sorry. On the AP knee, you can tell this is a child because they have epiphyseal plates or epiphyseal lines. So the bones are still growing, especially the long bones are very distinct in showing you those epiphyseal plates. You want the femorotibial joint space open. The knee should be centered in the collimated field. The articular facets should be profiled. And you want optimal exposure factors. Now this, I don't know, this looks a little odd to me. It could be because it's a child, but it almost looks a little grainy, almost like there's quantum noise in there. I don't know that there is, but it just looks a little off. In an AP knee, you have to visualize the distal femur and proximal tibia and fibula. That femoral tibial joint space should be opened. Okay, and you want to make sure there is no rotation. There should be very little superimposition of the fibula underneath the tibia. Then we do our two obliques. So the first one we're going to look at is a 45-degree medial oblique, and this is found on page 247. Now, I didn't say back on that initial image, but obviously if you're on a 14:17 or a 16:16, there is collimation. You would likely collimate to a 10:12 lengthwise. You can see the light field here. That's probably what they have it collimated to, is about a 10:12 lengthwise. The central ray is still 1/2 inch distal to the apex of the patella, and you have to take the angle off of the central ray. Okay, so there's no angle on the central ray. Now on this, if you look on your cheat sheet under the 45-degree medial oblique, you see an acronym, which is FITE, F-I-T-E, and the F-I stands for on the internal rotation, which this is called a medial oblique or an internal rotation. This will demonstrate the fibular head and neck free of superimposition from the tibia. Okay, so we'll look at that image in just a minute. So this is a 45-degree medial oblique. So you rotate the leg 45 degrees medial. Central ray is 1/2 inch distal to the apex of the patella. But notice, with the leg rotated, you're not directly below it. You're still splitting the part in half. So this line is running down the middle of the leg once it's turned. Obviously, when they medially rotate, the apex of the patella is going to rotate as well, the entire patella. So instead of being over here, having the center over here and having all that anatomy, you're still in line with the center of the leg, but this line is at the level of a 1/2 inch distal to the apex of the patella. It hangs femur up, so marker placement is fine like that, even though typically when we think of right, we think to the right of the part, but that does work. Then we do a 45-degree lateral oblique, and that's found on page 248. Same collimation. Now you have the patient roll their leg out 45 degrees. Central ray stays the same. If you've got the apex of the patella, you go 1/2 inch, but instead of being right below it, you still split the part in half. So this line would run right down the middle of the leg. Again, no angle on your central ray. And if you look at the acronym, the TE in FITE says that the tibia is free of superimposition. It's actually in profile on the external. So FI, fibular head, is free of superimposition on the internal, and the tibia is in profile on the external. Notice it also says the patella is half on, half off the femur. So we're actually going to look at both of those graphs in this next slide. So this is the 45-degree medial oblique, because you can see this is the fibula, which sits lateral, so the knee is rotated medially. Okay, and on the FITE, F-I for F-I-T-E, the F-I says that the fibular head and neck are free of superimposition on the internal. And you can see right here, you can see the fibula, the whole thing, there's no superimposition by the tibia. So that is a really good 45-degree medial oblique. And typically also another key thing to look for on the obliques is that the patella is half on, half off the femur. in both obliques. So you can see right here, the patella is right here is off the femur, and then right here is on the femur. Okay, this one a little over, but you can see patella right here off femur, and this portion is on the femur. So if the patella is half on, half off, that's a good indication that you have correctly positioned your obliques for your knee. So on the medial, the proximal tibiofibular joint space is open, which means that the fibular head and neck is free of superimposition. In the lateral oblique, the fibula is superimposed over the mid-tibia, and it places the tibia in profile. And then in both, the patella sits half on, half off the femur. Okay, so now you've done your AP, your 45-degree medial oblique, and your 45-degree lateral oblique. And then we do a lateral, which is actually a mediolateral projection. So the leg is rolling out, just like we did for ankle, calcaneus, foot, tib fib. Everything we've done so far, we roll the patient laterally. So on the medial lateral, patient lies on their back, and you pretty much want to have them roll up on their side, but they're going to keep their unaffected leg back behind them. If they bring that leg up and over, they tend to rotate too much, and you would have an over-rotated lateral knee. So the unaffected leg stays behind. And remember that the central ray on this is angled 5 to 7 degrees cephalic. And what this should do, if you angle 5 to 7 degrees cephalic, it should create the medial and lateral condyle to be perfectly superimposed. Because remember, the reason we're doing that is if we look back, we said that there is a 5 to 7 degree difference between the medial and lateral condyle. So that 5 to 7 degrees, in order to perfectly superimpose them on the lateral knee, we angle 5 to 7 degrees cephalic to throw them on top of one another. And the central ray on this is 1 inch distal to the medial epicondyle, which is pretty palpable. If you feel on the inside of your knee, you can usually feel, I don't know, it's like a rough prominence on there. But if you look, you can also see that you can make out, you can pretty much make out her patella right here. So central ray is still about the same as far as being a ½ an inch below the apex of the patella. So just like with all the laterals, like we have the same central ray, but since you can't see that, then typically what you end up doing is keeping still in line with that, but now the central ray is going to be in the middle of her leg up here. Okay, so it's 1 inch distal to the medial epicondyle, which still places you in the same general area as a ½ an inch below the apex of the patella. So they roll lateral. You want to make sure you're looking at the anterior surface of the patella. It should be perpendicular to the table. You can look at the shadow that it casts, but you want to make sure that that patella is perpendicular to the table. The patient only slightly flexes their knee when they do that, maybe 20 or 30 degrees. But you want to make sure that the leg is in a true lateral, or the knee is in a true lateral. So the epicondyles will be directly superimposed, and the patella, the plane of the patella, is perpendicular to the IR. All right, and notice, I'll just talk about it while we're in here. I said if you're doing trauma views, then the trauma lateral is actually a horizontal beam projection, which we call a cross table, either written out cross or X for cross table lateral. And that's what this little inset picture is in here. So she's lying on her back, the knee is slightly bent, the IR is on the other side, and the beam would be horizontal, so that you can still demonstrate a lateral position with a horizontal beam. We're not looking for air fluid levels. If we were and it was a horizontal beam, we would call it a decube. but since we're not looking for air fluid levels, we just call it a cross-table lateral. Right? And when we look at the lateral radiograph, again, really good lateral knee because the medial and lateral condyle are almost perfectly superposed. You can see a little tiny smidge of difference right in here, but otherwise just an excellent lateral knee. The patella, the surface of the patella would have been perpendicular to the IR. The condyles are perfectly superimposed. The patella is in profile. The patellofemoral joint space is wide open. And as far as exposure factors, that is excellent. Right here, this is the tibial tuberosity. You can kind of make that out right there. So excellent, excellent lateral knee. Now, occasionally, especially if they are going to an orthopedic or an outpatient, sometimes they will ask for AP weight-bearing knees. And they're typically done bilateral AP weight-bearing knees. So the patient would just stand with their back against the wall bucky. Their feet would be positioned straight ahead with weight evenly distributed on both feet. And the central ray tends to be perpendicular to the midpoint of their knees, about a ½ inch below the patella. Again, the apex of the patella. So right where you normally would, but now you're just going to use a perpendicular central ray. You can see on here they've got the left marker because that's the left knee, and this is actually an arrow showing that the patient is upright. You could also mark left and right knee and then annotate on there that it's weight bearing. That would be something else acceptable. But a lot of times they will do this just like I said to see how well the bones, the joints behave under pressure. So AP bilateral weight-bearing knees. And if we look at the images of this, you can see that the joint spaces are not open because at this point we had a perpendicular central ray and we were not angling based on the patient's body habitus or the size of their thighs and buttocks. We didn't measure anything. We kept it perpendicular, but it's not going to be as open a joint space because you're not angling either cephalic or caudal. You're keeping it with a 0-degree angle, right? And then they point out the articular facets, the tibial plateau, and the intercondylar fossa. And then these are the intercondylar tubercles. And that's what an AP weight-bearing knees would look like. Now, the last view that we do in a routine knee is actually called a sunrise view. Okay, and there's multiple ways to do the sunrise view. So you're trying to demonstrate what's called the patellofemoral joint. And if we look back, patellofemoral joint is this right here. So you're trying to demonstrate that, and we do what's called a sunrise. Now, when I say you're trying to demonstrate it, I recognize that on the lateral you're demonstrating it, but we can demonstrate it 5 different ways. It's a tangential projection, so skimming the part, and the different views that you could take are the Merchant view, an infrasuperior, the Houston method, the Settegast method, or the Hobbs method. Okay, so all of these are considered sunrise views, all of them. The Merchant, the infrasuperior, the Houston, the Settegast, and the Hobbs are all sunrise views. And you would do whichever one the facility wanted done, or sometimes they'll tell you they don't really care which one you do as long as you get it. Okay, so it's kind of like, remember when we did barium enema and we had the AP axial butterfly, and there was 4 different ways you could do it. You could do the AP with the angulation, you could do the LPO with the angulation, you could do PA, or you could do the RAO. So we only needed one of those butterfly, and the purpose was to straighten out the sigmoid colon. but we did one of them. Same thing. There are 5 different sunrise views to demonstrate the patellofemoral joint space. We do one of them. So we're just going to kind of look through just so you can get an idea of all the different things. Now this thing here, that's what the slide is of. This is actually called a merchant board, or it's a leg support and IR holder. Okay, so if you look back, you could see that in this particular picture, she's sitting on the table, her legs are strapped and coming down, and then this holds the IR so that when this central ray right here skims the part, it's going to end up projecting both patellofemoral joint spaces onto that image receptor, and you're going to get a really good sunrise view. So that's called a merchant board. All right, and the merchant view is actually on page 258. Okay, so on all our techniques up to this point, we've used 80 kVp at 4, and we've been in the Bucky. Now you can see that we're more tabletop. There is no grid, no Bucky. The technique for these is typically 75 kVp at 3 mass. In this particular view, the bilateral merchant method is on page 258. And this is where you would utilize the merchant board. And your central ray is 30 degrees from the horizontal plane. So meaning it would start out horizontal, and then they're angling 30 degrees down. So this right here is 30 degrees from horizontal. Okay? And that is the bilateral merchant method. And this is actually what it would come out like. Okay, so the intercondylar sulcus and patella are well visualized. The femoral patellar joint space is open. You can see right here, this one is really nice and open. This is good. It looks like there is some displacement of the patella because you can kind of, this looks pretty straight, but this looks a little bit off. Now it could have been that the leg was out a little bit. That could be due to injury, totally dependent on what was going on with the patient. So that's one view that we can get called a sunrise view, typically because they usually reference this as the horizon and this is the sun rising up. So sunrise view. We can also do what's called an infrasuperior projection, again, meaning that the projection, so the tube is down here, okay, tube is down here, and it's coming in inferior and exiting superior. So infrasuperior projection. Infrasuperior. There's 40 to 45 degree flexion of the knees, and the central ray is angled 10 to 15 degrees from the lower leg. All right, so not to keep drawing all over it, but if this is the angle of the lower leg, then the central ray is going to be 10 to 15 degrees from that. Okay, so 10 to 15 degrees from the lower leg in order to make that. And what it does, the central ray will come right up and kind of pick that patella and throw it up here, and it'll open that joint space just like it did. So it just literally skims. It's called a tangential, or it's a skimming projection, where your central ray is coming right here just to kind of pick that patella off. And I don't know that I have an image of the infrasuperior, but it literally would look very similar to this. The different methods, if you've noticed, like so far we had the merchant method. That's likely named after the person that came up with a view. Same thing with Setagast, Hobbs. Those are probably named after radiologists that came up with these images. Infrasuperior is just naming the projection, meaning that the path of the central ray is coming from the inferior portion of the leg, exiting the superior portion of the leg. This is a lot of times similar to what we do. I'll show you the one we typically do. The Houston method, this is on page 259. All right, so the Houston method, you can see the patient's lying prone. They kind of, that sheet is around the patient's leg to kind of hold it. It's got a 50 to 60 degree flexion from full extension of the lower leg. And the central ray is angled 45 degrees cephalic. All right, and again, anytime you see the central ray like that, it's just going to come in and do your, just kind of pick that right off. Okay, and that's the Houston method. I just said that central ray was 45 degrees cephalic. They're telling you the central ray is 15 to 20 degrees from the lower leg, which is interesting because it's different from what the book, this particular picture in the book says that it's a 50 to 60 degree flexion. This is referencing to flex the knee 40 degrees. So I apologize. This is 50 to 60 degree flexion. And with this, it says that the central ray is angled 45 degrees cephalic. So that when they're saying 15 to 20, what they reference is that if you angle 20 or less, it prevents the patella from being drawn into that patellofemoral groove. So that kind of does make sense that they don't want you to angle too much because you'll actually throw the patella right into that groove. Now, all of those are great. This is typically the one that we attempt to do. This is a Settegast variation, and this is found on page 260. All right, so the patient basically sits up and holds on to the image receptor. You can see she's got it about mid-thigh. And then that central ray is angled to the patellofemoral joint space, again about 15 to 20 degrees from the lower leg. All right, so this is just going to kind of skim the part, throw the patella right up here into a nice sunrise view, and this is actually what it looks like. Now, shield placement on this, not really ideal, do you think? Because where's the beam? The beam is going right here. So this shield, when I'm trying to tell you guys about shielding for lower extremities especially, this shield should be draped like that, but in here. Like the shield, in my mind, should come across her, down, drape down in here, and then come back up. All right, you want something like this right here, so that you're, I mean, that tube, look at the way the tube is angled. So radiation is coming right there, and you've got the shield laid over her like that, but you're not doing anything to protect the gonads at all with the shield the way it is. All of the images would look similar in that what it would do is project the patella up like that and ideally open the patellofemoral joint space. But when I was saying when you overflex the knee on some of these, the disadvantage, it said, was that it draws the patella into the intercondylar sulcus. So what it's doing right here, you're actually obscuring because it's pulling the patella down in to that sulcus, versus if we looked back at the other one, you had a nice open joint space. Like you could see all the way through that. Okay, so this one that we just had, it's not horrible, it's just overflexed. The knee is flexed too much. Then we have what's called the Hobbs method, or a supero-inferior sitting tangential. Again, supero-inferior refers to the path of the central ray, so it's coming from up above, from superior, exiting inferior. And you can see they've got the patient either seated on the end of the table with the IR on a footstool. That's one way to do it. Or you could have the patient kneel on the table and again have the tube above the patient and come down like that. Says that the patient's typically seated with their knees flexed. The IR in that particular inset is placed on the stool to reduce OID. And you're typically at a 48 to 50 inch SID so that you reduce magnification because of the OID that you've got in here. Okay? Not so much OID here, but definitely have OID here, so you counteract that by raising the tube. And then that Hobbs method, again, the images look very similar in that you try and open that joint space and get a good clear view. Okay. If you do these sunrise views correctly, then the patellofemoral joint space is open. Again, there's 5 different ways to do those sunrise. You only do one. Whatever one you choose or whatever one is protocol for your site, that is the one you do. I can tell you in the orthopedic clinics, they tend to do this kind, except they have their detectors, like their wall buckies can come down. Their wall buckies can come down and then they can angle. So a lot of times what they'll do is they'll bring the wall bucky down and they'll angle it. Let me get rid of that. They'll angle the wall bucky with the knees, and then they'll end up having the patient, the tube is usually right by the patient's head, but then they shoot right down like that, and it gets a gorgeous image of that. But this is typically at an outpatient center. If you're at an inpatient, if you've got an inpatient that you're trying to do that, then to me, the one that I've always done, because I just find it easier, it's more comfortable sitting like this. It's as long as they can hold that IR, that's the biggest challenge, because they tend to get either a cramp in their thigh or a cramp in their lower leg. But this to me is the easiest method, as long as you make sure your shield placement is correct. All right, one of the last things, I added this to show you because it is in your pathology sheets, but it is not in the book, and that is a bipartite patella. Okay, a bipartite, bi typically implies two-part patella. So what happens is you end up with 2 separate bones from birth that remain separate throughout their life. Okay, so you kind of see on here, when you look at it AP, you can see that there's this little piece here is separate from this piece here. All right, and then you can see that right here is separated. Now, most of the time when these images are done and somebody sees that, they immediately think, oh my gosh, it's a fracture. Nice open joint space right there. But it's not a fracture, it's actually a congenital anomaly, meaning they're born that way. From birth, it just forms as 2 separate bones. So a bipartite patella is where it forms as 2 separate bones and they remain separate. And there's actually 3 classifications. I just put this in here because it was interesting, and the classifications are based on where the separation is. I can't remember the exact names. I want to say it's inferior, lateral. I don't, honestly, I don't remember, but type 1 is where the separated piece sits below the bigger piece. Type 2, it sits to the side or laterally to the piece. And then type 3, it must have to do with the shape of the piece or the way that it's separated and sits more like at 1 or 2 o'clock if you were looking at a clock. If we look back at the one we just had, it actually looks like a type 3, because when we just looked at that, we have the one piece here and then this piece right here. So to me, that resembles more this right here. So a type 3 bipartite patella. Nothing wrong with the patient. Typically they can present, it might hurt. based on an injury, and that's why typically most techs think it's a fracture, but this is not an actual fracture. This is a congenital anomaly. All right, now, the last few things we're going to talk about is actually they can order views for the patella by themselves itself. And the views for a patella are a PA and a lateral. Okay, now for a PA patella, this is actually found on page 256. And you might say, why are they doing a PA patella? But if you think about it, a PA patella would place the part closer to the IR, correct? Because the patella sits anterior. So with the patient PA, the part is actually very close to the image receptor. So there's a reduction in OID, which means that your image should appear better. The central ray is perpendicular to the mid-patella area, which is basically the popliteal crease. That's the crease in the back of your knee. That's where you would center. Midway down the leg, so this crosshair goes in the popliteal crease. This one would run down the center of the leg. Perpendicular central ray places the patella closer to the IR, and this is actually a PA patella. So the patella should end up in the center of the collimated field. There should be no rotation. All right, and you can tell it's a little bit radiopaque, a little more radiopaque on there. You can see this is the base of the patella. This is the apex where it comes down to a point. All right, and that was done PA. And then the other view we do is a lateral, which is on 257. The central ray is to the mid-femoral patellar joint, and you don't want the patient to flex their knee very much, only 5 to 10 degrees. Basically because if they did fracture the patella and you bend the knee too much, you could actually separate or dislocate the fragments of the fracture. Okay, so again, unaffected leg stays behind the affected leg, slight 5 to 10 degree bend in the leg. Central ray remains perpendicular, and it's to the mid-femoral patellar joint. So kind of right behind the patella and in front of the femur. So kind of just picking down. And when we look at that, we want the same kind of criteria. You want the condyles should be on top of each other because this should be a true lateral. So if the epicondyles are perfectly superimposed on there, medial and lateral epicondyles should be perfectly superimposed. And the patella, the plane of the patella should be perpendicular to the IR, which opens this joint space. Okay, so your indicator of a good lateral knee or lateral patella is that both epicondyles, the medial and the lateral, should be directly on top of one another. Right, just like we had looked back in that picture in the beginning where I had drawn on it. This one, excellent as far as really, really good lateral. And then when we looked at this one, okay, now these are really not on top of each other. The medial and the lateral condyle, and obviously condyles and epicondyles, they're not perfectly superimposed. So that's what you're looking for, is perfect superimposition to know that you've got a really good lateral. Okay, so a routine patella consists of a PA and a lateral patella. And that brings us to the end of chapter 6. So if you have any questions or comments or concerns, please make note of them, and we will discuss them in our next session. Thank you so much.